Can you hear me now?
We can hear you, I believe. Yes.
All right. Sorry, I thought you said you were still on mute, so I apologize.
Nope, you're good.
All right. All right. Hello to everyone. My name is Alex Mantegui, and as Natasha just said, I'm a new pediatric and adult ears, nose, and throat doctor here at Barton. And today we're going to be discussing an overview of pediatric ears, nose, and throat conditions and treatments as part of Kids ENT Health Month. So, a little background about myself. I'm originally from Akron, Ohio. I went to Ohio State for undergrad, then Ohio University for medical school. I did my residency in Philadelphia through PCOM and Drexel University, and then did an extra year of pediatric ENT fellowship at UC San Diego at Rady Children's Hospital. So 5 years first in Philadelphia, another year in San Diego for additional training. Then I came back to Philadelphia and practiced for 3 years at St. Christopher's Hospital for Children in Philadelphia, doing pediatric otolaryngology. So beyond that, I'm also a peer reviewer for the Ears, Nose, and Throat Journal and the International Journal of Pediatric Otolaryngology. And I'm also an associate professor of otolaryngology, head and neck surgery at Drexel University College of Medicine. An opportunity arose here, and I've been to Lake Tahoe a few times when I was a kid, and I loved it. And so with the pandemic and the opportunity that popped up here, I thought that was time for a change, and it's been great so far. I started in October of 2020. So, ears, nose, and throat, or ENT. A lot of people have a lot of misconceptions of what exactly it is, and a lot of people ask me, that's just like a sinus doctor, right? And so formally, an ENT is a specialist in otolaryngology, head and neck surgery. The oto stands for ear, and then the laryngology is more the voice box. That's actually shortened from otorhinolaryngology, where the rhino part was, addressing the nose. But in layman's terms, it's a doctor of most things in the head and neck, but not really including the brain, spine, or the eyeballs. We deal with many issues, including ear infections, tonsil and sinus issues, allergy issues, hearing problems, and head and neck cancers, in addition to voice issues as well as nasal issues. So a wide variety of issues. And beyond that, there's also further specialization within ENT, in pediatric ENT, rhinology, and sinus surgeries, and these are all fellowships you can do to gain additional training beyond the residency. So pediatrics, sinus surgery, head and neck cancer surgery, otology, and skull-based surgery. That's basically saying complex ear surgery. Head and neck cancer surgery are for complex cancers as well. My screen is cut off, but there's also laryngology, which is surgery of the voice box itself. So let's go over a little overview of the anatomy of the ears. The ears are divided into the outer ear, the middle ear, as well as the inner ear. The outer ear is your ear canal and the outer ear proper itself. And one way of thinking about this is how sound comes in through the ear. Sound comes in through the ear canal and it vibrates the eardrum. The eardrum is attached to 3 little bones called the ossicles that transmit sound from the vibration in the eardrum to the cochlea, where sound is processed. Oops. Sound is processed there in the cochlea and then sent to the brain via the auditory nerve or the cochlear nerve, as it's also known. When we look at the the middle ear is comprised of basically the dividing point is the eardrum. So everything to the side is the outer ear, and everything in the middle, including the ossicles, is the middle ear. The inner ear involves the cochlea, as we discussed, and attached to the cochlea are also the semicircular canals. These are our balance centers. There's 3 little hula hoops, one for each axis of movement. So this is our, you might hear where your balance center is in your ear. This is it. Now the ear, or the middle ear, I should say, is connected to the back of the nose via a tube called the eustachian tube. The eustachian tube is the thing that pops our ears when we go flying. If you ever go diving in the water, like deep in the water, scuba diving, it's what causes your pain in the ears. Again, its whole purpose is to equalize pressure in the ear in the back of the nose. You definitely hear it if you're going over the hill, to Carson or to Reno. Now, if there's ever a problem with the eustachian tube, you can get a backup of fluid and pressure. And if fluid and pressure build up, eventually you can get a buildup of fluid in the middle ear. Kids are very prone to middle ear infections because of the eustachian tube. And really, the eustachian tube is the root of all ear infections. Because if it's not doing its job properly, like we said, negative pressure gets backed up into the ear, which can cause fluid development, which can over time lead to ear infections. The reason kids and infants are more prone to it is because their eustachian tubes are naturally smaller and they're flatter. As we age, the eustachian tube gets bigger and it has more of a downward angle and basically does its job even better. Another reason is that kids have larger adenoids than adults do. And the adenoids are just like the tonsils, but they're in the back of the nose where you can't see them. And the adenoids, if they're large, can actually crowd the eustachian tube, causing eustachian tube dysfunction, which can ultimately lead to ear fluid and even ear infections. So let's talk about hearing loss. We divide hearing loss into two main categories, conductive hearing loss and sensorineural hearing loss. Conductive hearing loss is when the sound does not conduct well through the ear. That might be due to wax in the ear. That can be due to fluid buildup in the middle ear due to that eustachian tube dysfunction. It can also be due sometimes we can be born with it or it can develop later in life, is where you can have a fusion, an abnormal fusion of the bones so they don't move well, or the bones are not articulated together. For example, if you have chronic ear infections, it can erode this joint right here. This is called the malleus, the incus, and the stapes. So this is the most commonly eroded bone joint in the middle ear. A large hole in the eardrum can also cause hearing loss. But in general, conductive hearing loss the severity only ranges from mild to moderate. You do not see the severe to profound hearing loss that you do with nerve-related hearing loss. So the nerve-related hearing loss is mainly due to issues either in the cochlea and the little hearing hair cells there, or the nerve itself on the way to the brain. So nerve hearing loss can affect one or both ears, and it can be acquired, meaning it can be from a bad infection. There are some medications that do it, such as there are some IV antibiotics, and chemotherapy agents can cause hearing loss. And patients that are born with a number of neonatal issues, such as premature children, children that are on the ventilator for long periods of time or intubated for long periods of time, patients that are under the blue light when they're born for long periods of time. And there also, nerve hearing loss can be congenital. Conductive hearing loss can also be congenital, but it is more common to have nerve hearing loss be congenital. And the severity can range from mild all the way down to profound. Some babies are born with complete hearing loss, and those are the patients that we often need to perform cochlear implants on. So as part of Kids ENT Month, they put out some graphics, and this is just a graphic basically telling you guys to make sure, kids' ears are sensitive, as are all of our ears, but especially kids with their growing ears. They need to be careful with loud noise exposure, whether that's loud concerts, target shooting, just loud noises, listening to loud music on high volumes through earbuds or headphones, or like we said, loud concerts. So here's a picture of a girl wearing headphones, and I often see, like when I go to concerts, I see babies like with those cute little headphones on their ears. So just something to be mindful of and wary of. So middle ear infections. Kids, like we said, are very prone to middle ear infections because of their eustachian tube anatomy, which eventually they grow out of. And it's one of the other reasons that adults you see them far, far less in adults. Recurrent ear infections show up can be bacterial or viral, but typically middle ear infection shows up as it's painful, you have a high fever, and kids show it by being fussy and having poor sleep with sleep interruption. And rarely, if you have a bad enough ear infection, it can actually burst through the eardrum, causing pus in the ear, which can cause a draining ear. It causes temporary hearing loss because the sound is not able to conduct well due to that buildup of fluid. Now, that's very different than otitis media with effusion, which is basically fluid that's in the ear, but it's not infected. It's sterile fluid behind an eardrum, but it can build up. It's not usually a painful thing, but it can cause muffled hearing. And if it's there over a long period of time, not addressed, it can lead to speech delay because kids aren't hearing well. To speak well, you need to hear well, and maybe even issues with learning if they're not able to hear well. There's typically no high fevers, no irritability, and if left untreated, it can eventually lead to an injury in the hearing bones or the eardrum. There are a number of risk factors, including daycare and secondhand smoke. These slides are getting cut off just a little bit, so I can't read all of it. And let's see what a normal eardrum looks like. So a normal eardrum is, you can see, there's a pearly gray appearance, and you can see that some of the hearing bones. When we say we can see fluid in the ear, what we're often really saying is that we're examining is that we can see fluid through the eardrum itself. And here, I'll show you some examples of what other ears look like, but I can't see any fluid. And just to go back to some of those risk factors for middle ear infections, we talked about the daycare. Daycare is probably the biggest one for kids. Kids are just rubbing their nose. They touch their face, they touch their nose, and they're passing around. They're passing around to all the other kids. Now, just nationally, talking to colleagues, we have seen a decrease in ear infections and ear tubes. And why is that? All the daycare centers are shut down because of COVID. So there's been a drastic decrease in ear infections. And like I said, I talked to my colleagues in Philadelphia, and there's been a big downward trend. Secondhand tobacco smoke, allergies are two other risk factors. Even if you're not, parents will often say, "Oh, I'm smoking outside." If you've been around any smokers, you can definitely still smell it. And there's been a proven association between secondhand smoke and middle ear infections. Allergies, enlarged adenoids, oftentimes genetics. Parents that had recurrent ear infections, their children are more likely to have recurrent ear infections as well. Down syndrome is another congenital, or not, I shouldn't say congenital, but it's another childhood syndrome that's often associated with middle ear infections. So, what does a middle ear infection look like? There you go. You can see it compared to the other one. It's a red, inflamed ear, and this pus is pushing against the eardrum. It is very sensitive. The eardrum and then the bony ear canal are some of the most sensitive parts in our whole body, and you can imagine like this pus is just pushing against it. So other middle ear pathology. When we talked about fluid, oftentimes it's sterile fluid. This is the appearance of what an effusion looks like that's not infected. This will mainly cause muffled hearing. Now, I don't know if you can see this very well, but sometimes if you have eustachian tube dysfunction, you can develop negative pressure in the middle ear, which leads to these things called retraction pockets, or areas of the eardrum being sucked in. This is a severely sucked in eardrum from severe eustachian tube dysfunction. And you know that because you can see all of the middle ear bones. Even the nerve to the face, the thing that makes you smile, wrinkle your forehead, shut your eyes, that's also in the middle ear as well. And you can see everything in this example where the eardrum is just completely sucked in against all the bones. So when should you see an ENT specialist? Recurrent episodes of ear infections that are treated with or without multiple courses of antibiotics. And typically we're talking about 3 infections in 6 months or 4 infections in 12 months. High-risk children with middle ear fluid. So oftentimes with what we talked about with middle ear effusions, a lot of times we'll just watch those to see if they'll go away on their own. Because in general, 90% of fluid in the ear, I'm not talking about the ear infections, 90% of the time with kids with fluid in the ear, it actually will resolve by 3 months. However, if you have a high-risk child with middle ear fluid, a child with Down syndrome, with autism, speech or developmental issues, or developmental issues with cleft palate issues, or patients that have uncorrectable vision, those high-risk children were more aggressive with getting the fluid out and correcting the hearing, and not waiting that 3 months. Sometimes we may see worrisome findings on physical exam, like a bad retraction pocket, or rarely these things can spread to the bones in the back of the ear. If we see anything worrisome, then we're more aggressive. And basically, if we give that fluid some time to go away and it doesn't go away, then we'll go in and perform an ear tube, which we'll talk about in a second. So what are ear tubes? I'll have a video I'm going to show you in a second, but ear tubes are an incision in the eardrum to evacuate the fluid in the placement of a small, approximately 1 millimeter size tube. Tubes can definitely reduce the number of ear infections. That's been proven, but you can still, ear infections can still occur. They just occur, either they go away or they occur in a, the number is reduced. They reduce the severity of symptoms mainly because you don't have that buildup of fluid pushing against that eardrum. It'll just drain out. And oftentimes it's just asymptomatic, except an ear infection will show up as draining fluid from the tube when the tube is in place. And then the infections become much easier to treat. Once you have tubes, for the most part, you don't need to treat with oral antibiotics anymore. You just need to treat with ear drops, the antibiotic drops that get into the tube itself. There are some disadvantages, of course, and the operation is mainly done in the OR. Nationally, we're starting to do it in the office a little bit more. Complications are rare, and most of the time, the anesthesia is given through a gas via a mask. So literally, it's not so much an intubation, but the child has goes to sleep with a mask, and takes about 10 to 20 minutes to do both sides. And so one of the questions are, do you need to keep the ear dry when the tubes are in? And the answer is a little bit tricky because the National Academy actually came out with guidelines saying you don't have to wear earplugs when swimming or bathing. But we also have a number of patients that come in with ear drainage after getting dirty water in the ear. So generally I tell parents, try swimming, try bathing, and you can try without earplugs. But if they ever get one episode of drainage, we treat it with antibiotic drops, of course. After that point, I recommend earplugs. On average, tubes last on average 9 to 18 months before they fall out on their own. But sometimes they can stay in too long, over 2 to 3 years. And we sometimes have to go in and take them out. And in less than 3% of cases, 3 to 5% of cases, they can leave a hole in the eardrum, as shown here. But naturally, otherwise, the hole closes on its own in the other 97% of cases. And like we discussed, the ears can drain if you get chronic, with further ear infections in the future. Ear infections do go down, but the ones that do happen, they will show up as drainage. So, ear tubes, the indications. We kind of discussed it already, but any fluid lasting greater than 3 months, or any fluid in an at-risk child, kids with speech delay, or some of the other risk factors that we discussed. It depends on if you have a child that's speaking well and they have a small middle ear fluid buildup, oftentimes it'll go away in 50% of the cases by 1 month, 90% of the cases by 3 months. And we discussed if they have multiple ear infections, you're a candidate for ear tubes. And if there's any degree of moderate, if you have bad hearing loss, which in this case the threshold is moderate hearing loss, then we recommend it as well. Also, if a child has been treated with multiple antibiotics and they're on their third antibiotic, their fourth antibiotic, and maybe even in some cases they have to get an antibiotic shot, well, at that point they're like, okay, enough is enough. Let's just put in the tubes. There was a publication not too long ago from our Academy guidelines that did say, if you've had too many ear infections, but there's no fluid in the ear and there's no hearing loss, you don't have to have ear tubes. That's one of those things that we always discuss. That's a discussion between me and the parents to talk about the risks and the pros and cons of doing the tubes. You have some parents that say, "Oh, I want the tubes. This is ruining our quality of life. Making me miss work, making the child miss school." And other parents are like, "Okay, let's just watch and let's see if this gets better." All right, so I had all of these videos embedded in this PowerPoint presentation. But I think with the last save, it disabled them all. So they were all working perfectly a few hours ago, but like every thing in life, things don't always go according to plan. So I'm going to X out of here for 1 second, and I'm going to show you a video of
to avoid an possible injury. This must be just large enough to expel the ventilation.
We can hear it. We can't see it, though.
You can't see it. Okay, let me just...
But I wonder maybe if you, well, you might have to unshare and reshare
Yeah,
to get to.
let me just try this. New share. And let's try this. Okay. Now you can see it. All right. So sorry. So here we go.
Radial meningotomy is performed in the anterior inferior quadrant to avoid any ossicle injury. This must be just large enough to insert the ventilation tube. Take great care when manipulating instruments so as not to injure the anterior canal wall, causing bleeding.
Now you can see here, this patient had a
Infusion
thick
instructions, especially if it hinders the
fluid
ventilation
accumulation in the ear.
Take care not to use the too large suction so as not to induce sound trauma.
You can imagine how this would affect the hearing in the child.
The tube is inserted using microforceps, firmly holding the shepherd with a 90-degree angle. The anterior flange is directly inserted in the meningotomy, and the posterior flange is clipped down by lowering the forceps.
Okay. Oh, not yet. We're going to get to this in a second. Jumping the gun. I can't move my screen. We're going to come back to this. You know, actually, I'm just going to let you watch this for right now. Can you see the... This is what happens when technology does not work well with you. Okay, so we're back. We're back here. All right, so the pros of the ear tubes are they decrease ear infections, they allow for a treatment with ear drops instead of oral antibiotics, and you have fewer trips to the doctors. Complication, they can often come out early, sometimes they can come out too late. And oftentimes, if they do come out, you need to have another set of ear tubes. We discussed the risk there with a hole in the eardrum, which is less than 3%, and sometimes, and for some kids, they have chronic issues with drainage. We have water precautions with ear tubes. We discussed that, their pros and cons, and you talk to different doctors, and they'll have different protocols. So other issues we'll get to at a different time. Some kids are born without an ear canal or malformed ears, and these are often treated with reconstructive surgery, plastic surgery. We do often treat kids with skin tags around the ears, and this involves simple excision. Some children have keloids of the ear. This is often hereditary and more often seen in African Americans. This is a severe case, but these can often grow. You can see these in areas of trauma, such as from ear piercings. And these involve excision with steroid injection to help prevent recurrence. Eardrum holes are often another thing that we often have to fix. This can be done with skin from behind our own ear and or cartilage from our ear to help repair the holes. Cholesteatoma is a sac of skin in the middle ear. By itself, it's a benign condition, but over time, this sac of skin can sometimes erode through the bones of hearing and or the bones behind the ear. So this is, while it's not a cancer, it's something that needs to be addressed with ear reconstructive surgery that we sometimes have to deal with as well. So the nose. Let's go over the nose quickly, but the nose anatomy, we have 4 sets of sinuses in our nose. We often can feel our cheek sinuses. So when we talk about sinus pressure, most people are talking about the pressure to build up in their cheek sinuses or their forehead sinuses. And we have 2 other sets of sinuses. We have a honeycomb set of sinuses here called the ethmoids, and there's another one all the way in the back called the sphenoids. Now, a lot of times parents talk about kids having sinus problems. It's important to note, for many kids, the frontal sinuses and the sphenoid sinuses develop much later in childhood and aren't an issue early on. The turbinates are these little shelves on the sides of our nose and in the inside. Those are the things that get bigger and smaller when we get congested or when we get sick. They serve to humidify the nose and also to filter out all the bad stuff that comes in through our nose. when kids have bad allergies, these are the things that can get enlarged, and that's one of the big reasons you get congested. The nasopharynx is another word for the back of the nose. This is where the adenoids are in kids. Most commonly, you see adenoid enlargement in kids that are 2 to 6 years of age. Now, if they are enlarged, you can imagine those nasal secretions that build up, they have nowhere to go. So kids with large adenoids, they sound congested. They're always, and when they talk, they like have that nasally voice, like, hey mom, hey babe, that kind of thing. And they're snoring. And so you can hear them breathing from across the room when they're very large. Also, the tear duct empties in just below this turbinate right here. And there's a connection between the eye and the nose. Anyone who's ever cried, you can see that when you do cry, like you also get a stuffy nose because those tears are actually flowing down into the nose. So let's talk about some common problems in kids. Congestion and stuffiness is often due to enlarged adenoids in the back of the nose, or it can be from allergies due to the enlarged turbinates we just discussed. We'll talk about snoring, sinusitis, nosebleeds we'll touch on a little bit, but really the number one cause in kids for nosebleeds in kids is that they pick their nose. So if you ever talk to an ENT doctor or anyone bringing them in for nosebleeds, the first question you'll get asked is, have they been picking your nose? Rarely you can get large masses. I'll have a nice picture in here to show you some masses as well. And in kids, some kids can be born with narrow noses where they get a bony overgrowth of the nose entrance. So sinusitis, real sinusitis is denoted by thick yellow greenish nasal discharge. There's also fever. It can lead to chronic cough, bad breath. Kids are irritable, they're fatigued, and they have a headache. In kids, the number one cause for sinusitis is enlarged adenoids. So in that 2 to 6 year old range, the first thing your practitioner, your ENT doctor is going to do is get an X-ray to see how big the adenoids are. Treatment includes a combination of antibiotics, nasal steroids, neti pots, sinus rinses, and sometimes oral steroids. Now, in this case, you can have different things that can cause sinusitis, but polyps are one of the causes. One of the associations with sinusitis. This patient had something called allergic fungal sinusitis, where there was a fungal infection that led to an allergic inflammatory inflammation of the sinuses themselves. So these are just these thick secretions, and their nose is just packed. The sinuses, I don't know if you remember the last CAT scan, you want the air-filled pockets to be black. Black denotes that it's air. As you can see here, there's maybe a little bit of black right there, but otherwise it's completely packed. So some of the risk factors in children for sinusitis. The number one of the things we discussed, maybe the most important thing, is daycare. Kids pass this around to each other. Other things like enlarged adenoids and allergic rhinitis we touched upon. The common cold. If oftentimes it's an episode of, we don't define something as an acute episode of sinusitis until it's been 10 days, until the patient's had 10 days of symptoms. And the reason is oftentimes in kids, most commonly it starts off as a viral infection, but that viral infection causes damage to the lining of the nose, which can cause a seeding of bacteria such that you get a transition into a bacterial sinus infection. Asthma is another predisposing factor, cystic fibrosis, and patients that have immune deficiency or other things that can cause it. So what do? We talked about adenoidectomy. Removing the adenoids is the first line therapy for kids in sinusitis. This isn't true for adults because by adult age, the adenoids have mostly regressed. And all of this is performed through the mouth. And besides, taking down the bulk of the adenoids, which can, give more room in the nose, the other important thing to remember is the adenoids, can harbor bacteria. It's part of the reason kids with large adenoids oftentimes have recurrent ear infections because, if you remember, the adenoids are close to that eustachian tube, and the bacteria from the large adenoids in the back of the nose can actually travel up the eustachian tube and contribute to middle ear infections in children. And just relieving that bulky tissue can reduce snoring. Oftentimes it's done with tonsillectomy if those are enlarged as well.
Dr.
We don't also do endoscopic sinus surgery in children beyond the adenoids. So, but there are cases that, patients have continued symptoms. We get a CAT scan demonstrating sinus thickening. And this is really done with a telescope through the nose. You know, your one hand holds a telescope, another hand holds instruments. And what we're doing is we're removing any diseased tissue, but also enlarging the openings into the sinuses. This improves drainage and ventilation, and also improves access for medicine delivered through the nose.
We're having trouble seeing your
nose,
presentation. I don't know if you can
these
try
are
to
other
reshare
conditions
the
associated
screen.
with sinusitis and the nose. Sometimes, because the sinuses are so close to the brain and the eye, infection can spread into the eye, and rarely can also spread into the brain, causing meningitis. In this case, in this child, it's spread into the eye because the lining between the eye and the sinuses is paper thin, and it doesn't take much to break through that. Sometimes we have to go in and actually relieve the pus in this area. Here's an example of a tumor in the back of the nose. It's called a juvenile angiofibroma, often seen in boys with really bad nosebleeds. It's a vascular tumor. It can block the nose and causes really bad nosebleeds. And oftentimes it can spread into the eye, into the brain as well. Here is an example of what a polyp looks like. In this case, it's coming from the entrance into the maxillary sinus. So what we're doing in sinus surgery, like we said, is removing diseased tissue and then opening those entrances. So here's what it looks like afterwards. You can see the entrance now into the cheek sinus called the maxillary sinus, and you can see that sinus all the way in the back called the sphenoid sinus. So this is what we like to have it look like at the end. This is what we don't like. So other common conditions in children. There's snoring and sleep apnea, which we'll talk about. Tongue tie is a common condition in newborns, and so some mothers have difficulty breastfeeding. That's due to this thing called the frenulum, which restricts motion of the tongue, and sometimes that needs to be snipped in the office. We'll talk about a number of other neck masses and lumps and bumps as well. So tonsillitis tonsils are the lumps of tissue. They're lymphoid tissue in the back of the throats, and they are part of the immune system. But your body and your neck, there's plenty of other your body basically picks up the slack. If you are, does everyone see my slides?
We're having trouble seeing them, Dr. Mantegui. I don't know if you can hear me. Can you hear me?
1 second. Let me just make sure everyone can see my slide, because I was informed that people cannot see my slides.
Are you able to hear me? I don't think so. Okay.
1 second. I apologize. I do all these Zoom calls all the time, and then of course this one has to be an issue. I see one question here. My thing is on mute. Can you hear me? My wife is telling me, give me some feedback.
Are you able to hear me, Dr. Mantegui?
No. Okay, I think my computer was on mute. That one. All right, is everything okay now? All right, how about now? Can everyone hear me now?
We can hear you. Can you hear me?
Yeah, I think my mute button was on my computer, so I didn't actually hear anything.
Oh, okay.
How long was that happening?
No, we could still hear you just fine. So that's a-okay. I just don't think we can see your presentation. So
is that for a while?
It's been since the video you shared.
Oh, my wife is here.
Everyone can hear you. So I think, yeah, I don't know if you can try to, if you want to try unsharing and resharing, I bet that would solve it.
Can everyone see the presentation now?
No.
It says your screen is being shared, so.
Do you want to try unsharing and maybe resharing?
How about now?
No. Oh, there you go. Now you're unsharing, so I wonder if you share again, if that would help. There you go. Perfect.
Oh, sorry about that. So the pictures that you guys missed, here's some of the pictures I missed. I'll just go past this. That's what fungal sinusitis looks like. Yum. Here's a snotty kid. This is the spread to the eye from a bad sinus infection, and this is the tumor in the nose, the angiofibroma. This is the polyp in the nose as well, and this is what it looks like after sinus surgery. Here's some large adenoids, or large tonsils in the back of the nose that can cause snoring and sleep apnea. And here's what here's what an episode of bad tonsillitis looks like. So this is where I think we're at right now. Okay, so tonsillitis, we talked about the tonsils are these lumps of tissue in the back of the nose, and tonsillectomy is basically recommended if you have recurrent sore throats or snoring with sleep apnea. So when we talk about tonsillitis is denoted by these white patches on the tonsils, a high fever, you can get lymph node swelling, and you can get voice changes. You can imagine if your tonsils get big enough, it sounds like you have a hot potato voice. You can also have difficulty swallowing. If it gets bad enough, miss school activities, and for some patients, if they can miss significant periods of school. So sleep disordered breathing is another way of saying if the tonsils get really big, it affects your sleep because those things are just basically falling in the back of the throat and choking you. It can affect up to 14% of kids in the US, and it can range from mild snoring to full-blown sleep apnea where you have choking and gasping. It's the most common treatment in children for sleep apnea, and it's the second most common surgery in America behind ear tubes in children. So sleep disordered breathing or sleep apnea can manifest itself in multiple ways. It can show up as poor weight gain or obesity, depending on the child. And if it's really bad, it can lead to long-term heart and lung damage. There can also be bedwetting that's due to a neurologic mechanism. There's also psychosocial side effects, such as aggressive behavior or decreased attention. Learning delays can be common, and poor school performance because basically they're not getting enough oxygen when they're sleeping. If you're not getting enough oxygen when you're sleeping, you can develop, your kids can be either hyperactive during the day or very poor, or they can just be really tired. And they're basically just not all there. So here's what a sleep apnea looks like. And there you go. That's a really bad sleep apnea. So it can show up as choking, gasping, or sometimes breathing pauses. Now, not all breathing pauses will last that long. Oftentimes you'll see it last for a second or two. So about 500,000 tonsils and adenoids are performed in the US each year. It's done under general anesthesia with a breathing tube, and it's often an outpatient day surgery. Recurrent tonsillitis, and when we're talking recurrent tonsillitis, we're talking about basically 7 episodes in 1 year, 5 episodes per year for 2 years, or 3 episodes per year for 3 years. If one tonsil is especially larger than the other one, it makes us think at least a concern for cancer, which is very rare in children, but it's still an indication to have your tonsils removed if there's a big difference between the two sizes. Cancer is very rare in kids, but the most common cause is lymphoma. If it is to show up. In rare cases, some kids just break out into bleeding tonsils, which sounds pretty scary, and luckily it's pretty rare. But that's an indication to have your tonsils and adenoids removed as well. Again, this was one of those videos that was working literally a few hours ago, and of course, it's not right now. So what I'm going to try and do here is share my screen. Hopefully I can do this a little more successfully than the last time. So, it's just difficult to toggle between the two. Can't see my screen. All right, how about now? Yes, we'll see now.
Looks good.
So this is an instrument called the coagulator. It melts the tissue away, and it does so at temperatures of about 80 degrees. So because it's lower temperatures than prior techniques, it results in less pain. Now this is a quicker version. Depending on the tonsils, some do take longer. These are what we call outy tonsils, such that they're easier to, if they're more projected out, they're a little bit easier to grab. Also, patients that have had multiple tonsil infections, a lot of times the tonsils can be scarred down, and those procedures take a little more time. But in this case, this is pretty much what we're doing. We're just dissecting it. You have to be very careful not to get too deep to get into any bleeders. But this procedure does provide for less bleeding than prior procedures. So technology has really come a long way. All right, so I'm gonna stop this. We're gonna go here, share screen, go back here, and okay. So you should all see my PowerPoint presentation now, right?
Yes.
Okay, so the airway. Let's move on to the airway now. And this was a video of what the vocal cords look like here, but again, that didn't go through. There's different causes of problems in kids. Laryngomalacia is a softening or floppy airway, often seen in the first year of life, that manifests itself as a squeaky baby. Vocal fold nodules and cysts, vocal fold paralysis, these are other issues that can cause problems as well. The foreign bodies are something we deal with more so in the children's hospital side than in an adult hospital, but sometimes, like in this case, this child had a bead stuck in the airway. The one thing to remember with airway foreign bodies is that every foreign body is an emergency, but button batteries are especially worrisome because those can literally burn a hole through whatever they're sitting in, the longer they're sitting in there. So sometimes kids more commonly put them in the nose, sometimes they can swallow them, and those are a true emergency. Anything in the airway, of course, is an emergency as well. Peanuts, beads, I've taken out bacon, I've taken out Legos. Not in the airway, but I've taken out a video game, like one of those Nintendo DS games from the esophagus as well. This is a video of us taking one out, but sorry, we're not gonna be able to see that today. And laryngomalacia, that's what we discussed as in terms of what a baby sounds like with squeaking. These are videos as well, and I apologize, we're not gonna be able to see those. I'm gonna try to come back to them at the end if we have any time, because I have them in another PowerPoint where the slides are actually working. But this is where a baby literally sounds like they're squeaking in the first year of life. And it's worse when they breathe in or when they feed. So when I say squeaking, it sounds like, I'm gonna do my best to recreate it here, but it sounds like, which is much different than the snoring that we hear with large tonsils. It's often related to reflux, and 90% of the time they grow out of it. 10% of the time they have to go to the operating room to basically do a small little clipping to open the airway. Croup. Oh, at least one of these words. That's what a croupy cough sounds like. That's due to a viral infection in the most narrow part of the airway just below the vocal folds. It leads to an inflammation and swelling in that area that causes that common cough. It causes also on X-ray this little narrowing in the airway. You can see the airway is this gray part here. and you can see where it narrows due to that narrowing from the viral infection. Most of the time, it resolves on its own. Sometimes they have to come to the hospital and get some steroids and a medication called racemic epinephrine to help open up the airway. Sometimes if it happens over and over and over, we do have to go and take a look at that area in the operating room to see how open, to see if there is a recurrent a lesion that's leading, like predisposing the child to recurrent issues. But oftentimes it's mostly viral. Other examples of viral issues are nodules in the airway, papilloma. This is a recurrent issue for some kids due to the HPV virus, where they need to go to the operating room multiple times to have these lesions shaved away. Vocal fold nodules are from voice box overuse. Oftentimes we see this in kids that are just screaming loud and yelling loud and using their voice improperly, most commonly in boys. I mean, to some of our surprise. And but these resolve basically with speech therapy. This is not typically a surgical problem. Most of the time they resolve with age and just telling, the kids just to basically just shut up. And other times, this is a narrowing of the airway, where if you some children that can have they can be born with this, or if they've had too many intubations in their life, that can lead to scarring to the area just below the vocal cords. This was one of the cases I had in Philadelphia, where there was a 16-day-old that was intubated. Well, he was intubated at 16 days, and he was intubated for about 2 weeks, and the breathing tube came out, and he had kind of a weak cry, and occasional noisy breathing with feeding. He was on a ventilator, but they brought him down so that he was on room air, but he continued to have feeding issues. So we went to the operating room and just to evaluate his airway to see what was going on, and this is what we saw. You can see his vocal cords here, and then you see this area below the vocal cords, which is a very interesting pattern of what we call subglottic stenosis. And if you compare it, the glottis is the vocal cords. The area below the vocal cords is called the subglottis. And what we had to do in his case, we had to actually do a emergent tracheostomy right, there and then. And that's basically a procedure where we had to give him an airway because he didn't have an airway. This was an airway. There's these little, owl eye things looking back at us. So we, the anesthesiologist gave him gas with a mask. And preferably when you do an airway procedure like a tracheostomy, you would like them to have a breathing tube in. But that was not a luxury we had with this child. So we had to act quickly, and the anesthesiologist gave mask anesthesia, and we made an airway into the child's neck. Afterwards, we went back in and did surgery on this airway to divide the scars. We did dilation techniques, and after 2 procedures, this is what his airway looked like here. So I believe it was 6 months later, the tracheostomy came out, and he was breathing okay. And quickly, we're going to touch on some neck masses because we're getting to 1 hour. There are different infections that sometimes we need to incise and drain to get the pus out. Thyroglossal duct cyst is one of the most common, if not the most common, neck mass in children. That's a swelling that develops in the area of the thyroid cartilage. It's a cyst that's attached to a bone that often needs excision. This is another example of that. Rarely you have some children that are born with congenital issues, such as, in this case, a teratoma that requires aggressive surgery. This is a child that we took to the operating room that had a teratoma that was a lot smaller than this. It was interesting that we actually took him to the OR for laryngomalacia correction, but then also noted that his airway was compressed by this mass, which was smaller in the 2 weeks prior to seeing him, but then acutely enlarged, compressing his airway. So we fixed the laryngomalacia, that squeaky stridor got better, but then we had to go back a few days later to take out this neck mass. So that's the basic, those are the basic questions. While we take some, I think we're going to have, some time for questions. As we do that, I'm also going to try and bring in some pictures and some videos, the ones that didn't make it into the screen.
Great. Well, I know we have a question right off the bat, and I hope you can still hear me. I'm assuming you can.
I can hear you.
Okay,
I was on mute before.
Okay. And just a reminder that if anyone on the call, on the Zoom call tonight wants to ask a question, you can ask that either in the Q&A box. There's a button at the bottom, or you can ask in the chat box, whatever's easiest. The first question, though, pertains to, I think earlier on you were talking about tubes in children, and if they haven't fallen out on their own, can they cause long-term damage? Can they stay in until they actually fall out, or should they be surgically removed after a period of time?
Yeah, so let me stop my share here. Tubes that have not fallen out, generally we give them 2 to 3 years to fall out. And if they haven't fallen out, we will either, sometimes depending on the age of the child, we can just literally pull it out in the office, or more often we go to the operating room and take it out.
There was another question about insects, and I don't know if that comes up commonly. It sounds like maybe if someone's sleeping or out and about, if that ends up becoming an issue, or how common that might be.
Yeah, insects, and I'm assuming the question is about insects in the ear. And sometimes they're alive and they can be, how do we say, immobilized with some lidocaine or an anesthetic in the ear. And often, but they are painful, especially if they're moving around. So those can be removed in the ENT office. And depending on the age of the child, the first thing you do, is try and basically kill it. And I prefer to just put some lidocaine in there. And sometimes that'll actually make the insect crawl out, as disgusting as that is. Oftentimes it'll drown it and kill it, and then we can remove it. Depending on the insect, sometimes it comes out easily. Other times their little claws can dig into the ear canal and can cause pain, in which case we need to go to the operating room and take it out. So the younger the child, the more likely we are to have to go to the operating room and take it out, depending on what we have in the clinic.
And one other question, can you just explain, with you being up in Tahoe now, what services you offer now versus maybe what people were going off the hill for, or if there are things that people still need to look to off the hill for?
Well, if we're pediatric general, certainly the whole range of pediatric and adult ENT, we're doing pretty much all of that at Tahoe. Some of the advanced, some of the advanced cancers, we are sending those to UC Davis, and some advanced, if it's a really bad middle ear disease or like really bad, there are some conditions where we feel like we need a subspecialist that had maybe done an otology fellowship or a head and neck fellowship. So there's one guy that had a really bad ear mass that was eroding into the brain. Those ones we're going to send off to UC Davis or to other academic centers. But otherwise, we're doing more or less the whole range of general and pediatric ENT. As far as the children's ENT, some of the, Barton will have kids 2 years and above. So their procedures for kids, and I should say that, but that does not include ear tubes. Ear tubes, any age, but some of the other procedures, they're limited as 2 years of age and older. Otherwise, we would have to refer to a children's hospital.
Great. There's a question about how can frequent nosebleeds be prevented?
Yeah, that's a great question, especially because here you're at a higher elevation and the humidity is lower. Prevention is mainly with the bedside humidifier and using saline sprays or saline gel, as well as Vaseline. Generally, I'll tell patients to use a little saline gel in the morning and a little Vaseline in the afternoon. And then in kids especially, avoiding trauma, avoiding nose picking, avoiding getting any fights. But the key is moisture. And if it's still bleeding despite doing all of that, sometimes we need to cauterize the septum, which is a little procedure we do in the office with a Q-tip that has like silver nitrate on it, and we literally touch the spot that's bleeding to cause a chemical burn. But most kids, I would say, are controlled with conservative measures like we just discussed.
Great. And there's another question about if you need to be referred by your primary care provider.
Partially, that's, some of the times that's a bit more based on insurance. If some insurances require you to, see your PCP first and get a referral from them, other insurances don't always require it. So if your insurance doesn't require them, come on in. We're more than happy to see everybody.
Great. That's all I've seen come through. I don't know if you had anything else you wanted to share.
No, I know we're at the end of the hour, but I can share some of those videos that I wanted to share earlier if people want to stay on. If not, then, thank you for giving me the opportunity to present.
Great. Well, maybe we can share those in some other way, maybe via social media or something creative, so that folks can still get a sense of it all. And this webinar tonight is on Facebook Live, and we've recorded it as well, so folks can come back and reference it at a later date if they'd like. But we'll go ahead and wrap it up since we are past the hour, and just really want to appreciate the presentation tonight, and we'll look forward to the next one. So thank you so much. Have a good evening, everyone.
All right. Thank you, everyone.